Our case today is 25-year-old male pharmacist, not non-hypertensive or diabetic. 2 years ago, he started to develop frequent attacks of palpitation of sudden onset and offset, associated with dizziness and near syncope. His 12-lead resting ECG showing normal sinus rhythm, no evidence of pre-excitation. Echocardiogram study was normal. He did 24-hour ambulatory Holter monitoring and showed the following tracings. First tracing is sinus tachycardia. We can appreciate BECs and BVCs. Here is a sudden onset of tachycardia, which is relatively wide complex, initiated by a PEC. Here is a sudden onset and offset of tachycardia, which is look like wide complex tachycardia. Another short run of tachycardia, another complex. We can appreciate also throughout the Holter isolated PVCs and BECs. Here another short run of another complex tachycardia. The patient scheduled for EB study. First we did a cardiac MR and multi-slice CT, coronary angio to exclude any scar-related VT because the electrophysiologist seeing the patient thought it might be a VT, just to exclude any underlying ischemia or any underlying abnormality in the cardiac MR. Inside the EB lab, this is a 12 resting ECG, normal sinus rhythm, no evidence of pre-excitation. We started by the placement of CS catheter inside the coronary sinus and a quadripolar catheter. Only two wires at first to study the antegrade and retrograde. Here the retrograde ventricular pacing from the quadripolar catheter showing 1-1 conduction. We will show now the during atrial single extra stimulus, the jump and echo beat. Here the jump and echo beat from 110 milliseconds jump into 209 millisecond AH jump and the echo beat. Here another evidence of slow pathway conduction because the AH interval is more than 200 milliseconds. Here the atrial double extra stimulus and evidence of echo beat without a jump, which made us further study the presence of any accessory pathway, especially at the post-receptor region. Here a single extra with echo beat. Here the short run of tachycardia with VA time 73 milliseconds. This patient had very frequent tachycardia during the study, which all was short run of tachycardia. We couldn't make any ventricular pacing during tachycardia because of the short run and easy termination of tachycardia. Here the 12-lead ECG during the tachycardia, showing wide complex with right bundle branch apparency. Here the VA time showing, as I said, 73 milliseconds was the earliest on CS56. And tachycardia cycle length 280 milliseconds. We inserted the ablation catheter to help us further to study the patient. Here the double extra stimulus with initiation of tachycardia. During vigorous atrial pacing, the patient went into atrial fibrillation. We did a DC shock and the patient cardioverted to sinus rhythm. This is induction via ablation catheter, double extra stimulus, 500 pacing cycle length, 500, 400, and 230 milliseconds. Here, where we placed the quadripolar catheter at the Hess region, we can see here eccentric activation during ventricular pacing from the ablation catheter with the latest A wave on the Hess catheter. Here, the eccentric activation during tachycardia with the shortest VA time on CS56 and the latest on the quadripolar catheter. We did a maneuver to differentiate, to confirm the presence of accessory pathway, which is the basal RV pacing versus apical RV pacing. Here, the basal RV pacing, we placed the catheter at the base of the RV, as shown in the fluoro. This is an RAO view. Here, the time from the stimulus to the earliest A on CS56 was 90 milliseconds during basal RV pacing. Apical RV pacing, we placed the ablation catheter at the RV apex and we paced from this side, showing a VA time, not a VA time, the time from the stimulus to the earliest A, 134 milliseconds, which confirmed the presence of an accessory pathway due to the difference in time between the basal, which is shorter than the apical RV pacing. Here is the ablation site. We started, of course, mapping the area of the posturoseptal area. We introduced the ablation catheter inside the coronary sinus due to the shortest VA time, which was at CS56. Here the ablation catheter very near to CS56. We started the mapping at this region. Here, during mapping, the earliest age during an echo beat was on the ablation catheter, the distal ablation catheter, preceding all the other A waves on the CS. Here, we tried to induce the very short runs of tachycardia, and we got also a very interesting signal on the distal ablation catheter preceding any other A wave on the other catheters. We started ablation at this site. As we can see, we cannot maintain the tachycardia because it always induced very short run of tachycardia by atrial single and double and extra stimulus. After we did the ablation at 30 watt for about 120 seconds, 2 minutes ablation, the post-ablation study, we couldn't induce any single echo beat. Here the atrial extra stimulus blocked, double extra stimulus blocked without induction of any echo beat or any tachycardia. Another pacing from the ablation catheter. Here we can see also a blocked double extra stimulus. Also, we tried to compare between the basal and apical RV pacing to confirm the abolish of the accessory pathway. The basal RV pacing here, as we can see, we can notice, of course, the concentric activation via AV node from the ablation catheter, but via pacing from the ablation catheter with the earliest A on the Hess catheter. We can see the duration from the from the stimulus to the earliest A on the Hess catheter during basal RV pacing to 122 milliseconds. We can confirm the presence of, we can confirm that this is a basal RV pacing because of the positive R wave on at lead ECG lead AVF, which show that we have an inferior axis. Here the apical RV pacing showing a time from the stimulus to the earliest A 212 milliseconds, which is shorter than the basal RV pacing, confirming the absence of any accessory pathway after successful ablation. Here the parahesian pacing. We placed the catheter at the His catheter, the quadripolar catheter, at the His region, increasing the amplitude to 20 milliampere and starting to decrease gradually until we capture a white beat. Here confirmed the absence of accessory pathway at the second beat from 178 millisecond to 211 millisecond, confirming the absence of any retrograde accessory pathway conduction. We decided to make an venography for the CS here to see if there is a pouch associated with this accessory pathway. Here the 12-lead ECG after ablation. Also we can see here a diagram showing the most common location for atypical accessory pathways. The anterolateral tricuspid annulus, where most Mannheim cases, right-sided Mannheim of course, present. Also the post-receptal region, which is a common site for atypical accessory pathways. This diagram also shows the RAO and the LAO, where the site we can ablate atypical accessory pathways. Here, the coronary sinus ostium, the inframedial right atrium at the second site, and the third site is the left post-receptal region. This is a case with a typical case with an electroanatomic map and the fluoroscopic view of the ablation procedure. The blue and right arrow show the ablation site at the coronary sinus ostium and left post-receptal region via transseptal approach. This accessory pathway is very atypical. It's almost a sheet, so it has to be ablated from both sides, from the left side and right side.